And we're getting almost to the end, so hang in there. Next speaker is Dr. Anand Prasad, who is Associate Professor at the University of Texas in San Antonio. We're very proud. Actually, Anand was one of our very first fellows that trained with us 10, 12 years ago. And he's now a world expert on the peripheral interventions and Associate Editor for CCI Journal. And he's going to present another complex case for us. So Anand, please go ahead.
Great. So hopefully this will wake everybody up a little bit. It's a little bit gory. So I'm going to present a shocking case of a liver transplant. Here are my disclosures, but my real disclosures are these three here, who all three of them trained me, and they're all sitting right here on the front row. So it's a little bit like being a fellow again, and hopefully I won't disappoint them. And please remember, don't blame them for what you're about to see me present. It's not their fault. So I practice at the UT Health Science Center in San Antonio, and we're affiliated with a large teaching tertiary medical center, university hospital. And this hospital does about 80 to 90 liver transplants a year. So one night I'm on call, and I get a call from the anesthesiologist who says, "Come quickly to the OR. A patient just had cardiac arrest on the table after a liver transplant, and we think he's having a heart attack." So nothing in that page sounds very good, right? So this is a 59-year-old gentleman. He has Hep C, known CAD, and had a non-STEMI not too long ago, and had 3 bare metal stents placed in his LAD at an outside hospital. He was on the liver transplant list and had been cleared by an outside cardiologist after completing 6 weeks of dual antiplatelet therapy. And a low-dose aspirin was continued in the preoperative period. So he underwent liver transplantation. Everything seemed to be going okay. The incision was being closed when the patient developed ventricular fibrillation and required defibrillation ACLS protocol. From then on, he became progressively hypotensive, requiring multiple pressors, and every 10 minutes he got epinephrine boluses. EKG had a new left bundle, and at baseline he had normal ventricular function, but the intraoperative TEE showed that his anterior wall and inferior wall were hypokinetic. So as I was headed in, the cardiology fellow was able to put a balloon pump in at bedside in the OR on the table. And so when I arrived, I see this scene. The patient has the abdomen closed, but not completely sewn up. Multiple drains are coming out, and they're putting out bright red blood. We don't know what this patient's INR, platelet count, or hemoglobin are. He was coagulopathic and had low platelets at baseline. He remains hypotensive, so the synthetic function of that graft is in question, and we don't know if that liver is even going to survive this hypotensive episode. So the transplant surgeon turns to me and says, "Can you take him to the cath lab?" So I guess everything you guys taught me would say, stay away from this, don't get into trouble, but didn't have a whole lot of choice. He's 59, just had a fresh liver put in. So we at least discussed it and said, okay, let's see what's going on. So here's his angiogram, and most of you can see that there's a tight stenosis involving his proximal LAD. It's hazy. It's right proximal to where his stents had been placed several weeks ago. So my questions were, should we proceed with PCI? If so, what's my strategy? Angioplasty alone or stenting? He has blood and platelets being transfused in the OR and in the cath lab. Do I give him heparin? How much heparin? In addition to volume resuscitation, can I do anything else for his shock? So my approach was to do whatever I can to avoid putting more metal into him in this scenario. So we took a PTCA-only approach, gave him a small amount of heparin, and surprisingly his ACT was actually relatively high. Used a compliant 2.0 balloon. And after angioplasty, he had, as expected, from angioplasty, had significant recoil and still had poor flow down the LAD. So I decided to use a angiosculpt balloon, which most of you may be familiar with. It's a nitinol covered balloon that scores the plaque. Several more dilations later, we have an acceptable PTCA result, no flow limiting dissection. So I was fairly happy with this result in the LAD. We then shot the right coronary. It's very tortuous and a hazy, ruptured-looking plaque in the mid right coronary. So right when I think, okay, great result, we can start, packing them up to go. We have, this lesion here, and I was doubtful whether balloon angioplasty alone would treat this lesion appropriately. Here. So I guess one slide's, okay, no, this is fine. So we've seen this before. The reason why you can't walk away from a second lesion is that you really want complete revascularization in your patients who are in shock. So this point has been made earlier, but we decided to go ahead and treat this lesion. We tried to deliver that same angiosculpt balloon down the mid-right coronary, but there was significant spasm of the vessel. And finally, we're able to deliver a compliant 2.5 millimeter balloon. And following that, we had, an acceptable result, no flow limiting dissection. The flow looked good. So the big question for me was, what now? The patient remained hypotensive. The wall motion on the TE looked better, but was still depressed. He required fluids and blood products throughout the PCI. And the epinephrine boluses continued every 10 minutes despite a balloon pump being in place. So my thought was, whether or not I want to use percutaneous LV support. If so, what about anticoagulation? Here's a patient that I was very nervous about anticoagulating who's actually actively bleeding. So a couple of points about that. As was stated earlier, if you look at the instructions for use, and it's actually a very thorough IFU if you take a look at it, you have to have a pretty high ACT when you first put the device in, and you want to maintain a moderately high ACT once device goes in and it's started up. So it's very important to anticoagulate these patients. But at this point, what's the worst that can happen? He's clearly not going to survive with persistent hypotension with a balloon pump and max pressors. So we went ahead and placed an Impella CP. We had first removed the balloon pump, and we noted suction alarms on the Impella console above P3 level. But at P2 it was stable, and he was getting 2 liters of flow per minute, which is more than we probably would have expected with the balloon pump in place. The hemodynamics stabilized with MAPS in the 60s, and no further epinephrine boluses were needed. And then we continued aggressive fluid and blood product resuscitation. So this is what the aftermath looked like. This is the exact case afterwards, giving you some sense of how difficult the decision to put the Impella in was, given the fact that he would need to be anticoagulated. So upstairs, the patient was given heparin, 800 units an hour. I just didn't want to compound one problem with another, so we wanted to avoid any thrombosis of the Impella catheter. The CP was kept in place for 36 hours, and he ended up getting 50 units of blood and platelets transfused over that period of time. The liver function did improve steadily, and he was weaned off of the pressors. We were able to take the Impella out on day 4, and I had the surgeons come close the access site. And at discharge, his EF was 45%, much better, obviously, than what he had in the operating room. So a couple of points have been made. I don't know if this point was specifically illustrated, but the question was, when do we put the Impella in? Do we put it in earlier or later after the PCI? And obviously, in our case, there was a lot of outside considerations regarding bleeding. But in general, if you can get the Impella in before PCI, the outcomes appear to be better. Now, one point that was briefly mentioned, but I think is worth discussing, is can the Impella be used with minimal or no anticoagulation? And of course, doing so would be clearly off-label. The empiric experience we've had in helping our surgeons post-CABG is that patients who need help weaning off of cardiopulmonary bypass, in some cases have gone 12 to 24 hours without anticoagulation. But in general, you should really avoid that. Signs that you may have thrombosis of your Impella catheter are an increase in the motor current, probably something that not enough people look at, but it's the green signal here. That's actually a very important signal to look at. Reduction in flow rates, early suction alarm. So you put the Impella in, the CVP was fine, you just put it in, and now you have suction alarms. You want to be aware of the fact that there could be thrombus in the catheter. And then don't forget about sheath thrombosis. Not only are you anticoagulating from the pump, you also don't want to have a femoral axis thrombosis. So the patient left the hospital 10 days after transplant. His EF is 65% at 1 month. And then 1 year later, we had a celebration of life for the patient, which included Dr. Washburn, who's our transplant surgeon, who helped us greatly. So with that, I'll stop and move on to the next speaker. Thank you.